There's a second reason, besides lead time bias, that's called overdiagnosis. Overdiagnosis can be explained in the same way. There are 1,000 men with progressive prostate cancer on the top, and they're not going screening. 5 years later, say 44% of them are still alive. The others are dead. Now look at people or men who go screening, and not every one of those who have cancer has a progressive prostate cancer, but most prostate cancers are non-progressive. So just to make it simple, there are 1,000 people with progressive and 1,000 men with non-progressive. Those who have non-progressive prostate cancer don't die by definition from prostate cancer, but they enter the formula. So these 2,000 enter the denominator and the numerator. And now, instead of 440 divided by 1,000, you have 2,440 divided by 3,000, and that's roughly Rudy Giuliani's number, 81%. See that? That's called overdiagnosis. You diagnose prostate cancer that's technically prostate cancer, but clinically irrelevant in the sense that the person would die with the cancer, not from. So the men among you, if you are lucky to live a long life, then you likely get prostate cancer. It's a good sign. Yeah. So rough estimates are, for the US, and they are really rough because nobody knows exactly, that if you have a group of 5 men who are in their 50s, one of them will have prostate cancer. At the time when Rudy Giuliani made this statement, the mortality rates from prostate cancer were about the same in the US and England. So how can it be that mortality is the same, but 5-year survival is double? The answer is there's no correlation between differences in 5-year survival rates, like US and England, and differences in mortality across all solid tumors. We design at the Harding Center for Risk Literacy at the Max Planck Institute so-called fact boxes. Here's one for breast cancer screening. A fact box summarizes the entire evidence available. The reference is given at the bottom, typically from a Cochrane review, but doesn't use any misleading statistics. There's no relative risks, there is no 5-year survival rates, they're just absolute numbers. And it's set up in a way that you have 2 columns. So there's also a text to that, which I haven't here, that explains it. So women age 50 or older. So you take 1,000 women from all these studies and 1,000 women who have no screening and 1,000 who have screening, and ask what happens 10 years later. And in the rows, there are not only the benefits, there are also the harms. The harms are usually not talked about. And breast cancer mortality is here. So in the no screening group, so on average, 5 women die from breast cancer 10 years later. And in the screening group, it's 4. That's what we had about. More important, or equally important, is total cancer mortality. The reason is one does not know always from what cause a person died, and many unlucky people have multiple cancers. So the total cancer mortality is the more reliable number. And as you can see, it's equal. So that means the one woman in the screening group who dies more from breast cancer, there's another one who dies more from another cancer. So there is no life saved here. Also, what's not shown here, the total mortality is also exactly the same. And you probably will rarely have ever heard about total cancer mortality or total mortality, and the reason is obvious, because that is not something that would convince too many women to undergo that. Then there are harms. And there are basically two kinds of harms, namely women who do not have breast cancer and get false positives, and then often biopsies. And this happens to many. One doesn't know exactly, 50 to 200. There's an interesting reason why the numbers for benefits are precise and the number for harms are so wide. Can you think why? Because most studies don't report harms at all. And then one gets these small samples. And the second harm is for women who do have breast cancer, but a non-progressive version. That is something that is technically breast cancer, but clinically irrelevant. So as many ductal carcinoma in situ are of this kind. So that means these women would have never noticed during their lifetime that they have this little change in the cell structure, and would be happily lived, but if mammography detects it, then they might end up with a lumpectomy or mastectomy, totally unnecessary. So, and that's an estimated between 2 and 10 in every 1,000 women. So this is what a fact book does. The fact box provides the information that's available at some point in time in an understandable way, and benefits and harms, so that every person can make up their own mind. There is no recommendation here. We do not want to continue the paternalism that has been there, and I think every adult person can make up her own mind. And if you can't, then you might be lucky and have a husband who also helps along thinking, or your friends. So anyhow, the studies we have done with fact boxes is to show they change the understanding and often also the decisions. So in one case, I had a gynecologist who always had recommended mammography screening, and as many of them didn't know the evidence. When he checked the evidence, he changed his way and actually used a fact box in order to inform his female patients. And he said, at the end, a third of them said, I'll want to do it nevertheless. A third said, in no case, why would I do this? And a third said, okay, ask me again in 5 years. So delayed decision making, but that's fine. At least we have informed decision making. And that's as far we want to get.